Let's go ahead and move on to our next presentation, which I think will address some of the questions that we're seeing around telehealth reimbursement. We're certainly seeing a lot of waivers come out that are affecting now, but even long term, we need to think about this. Very pleased to have with us today Dr. Zeke Silva, who is co-chair of AMA's Digital Medicine Payment Advisory Group. He's a radiologist, TMA member here from San Antonio, Texas. He's with the South Texas Radiology Group, medical director of radiology with Methodist Texas Methodist Hospital and Methodist Ambulatory and Surgical Hospital, and an adjunct professor of radiology at UT Health. So thank you, Dr. Silva, within your busy schedule for taking time to be with us today, and I will now turn it over to you.
Okay, thanks, Shannon. I'm going to go ahead and get my screen share going, and if you would, Shannon, just confirm a couple of things. One, confirm you can see the screen okay, and confirm you can hear me okay.
I can see the screen just fine, and I can hear you very well. Thank you.
Okay, perfect. So again, I want to just start by complimenting Dr. Libby's presentations. I think some of the follow-up questions, some of the content that was there, I'm going to try to touch on within the context of this lecture, but I think some of the points I'm going to share may prompt additional questions, and I know we have plenty of time to discuss. I was on a call yesterday, and some of you may have listened to it. So what CMS and what the White House are doing is they're having periodic calls. They're calling it experiences from the front lines, and it's just to show the level of interest, for obvious reasons, that this disease is carrying. There were about anywhere from 3,000 to 4,000 people joining each of those calls. And we were on this panel. I was one of the panel members, and of the 8 or 9 individuals that were talking about hospitals without walls and surge preparation, almost every one of them discussed the role of telehealth and their ability to deal with the crisis. In fact, and this is one of the more remarkable stories I've ever heard, one of the presenters, Ted Long, he's in New York City, made a reference to telehealth. Now, to be fair, this was an audio telephone type communication, but what they're doing in New York is when they receive 911 calls to their call center in a manner that 6 months ago, every one of those individuals would have had an ambulance sent out, would have been evaluated, and likely gone to the hospital. A significant percentage of those interactions and those phone calls are being transferred immediately to a telehealth physician, and he or she is helping to triage that patient and make decisions before the ambulance is sent out and before that patient ends up at the hospital. I mean, it just shows you, to build on Dr. Libby's points and others, just the role that telehealth is playing. And I just want to make the point, and this is really to the credit of everyone on this call, what we're seeing is the momentum that we've built up to this point in time is being accelerated at a rate that none of us could have predicted. And we should be, the public, the medical community, we as physicians, we as patients, should be grateful that we've reached this point. It's hard to imagine if we hadn't gotten as far along as we have, what the potential direction and outcome would have been. That said, let me start, and Dr. Libby mentioned a 3-year timeline that he was working on his efforts and sort of prompting what he was accomplishing. So kind of in a similar time frame, this goes back to about 2016. The AMA recognized a lot of the same dynamics that Dr. Libby described. And what we recognized was that as this technology, as this innovation, as this need, as this expectation was becoming real and necessary, that we needed to have a physician voice in the process. And we needed to have a physician presence to guide those discussions. And in early 2017, we formed a group. And as was mentioned by Shannon, I have the privilege of co-chairing that organization. And it's the Digital Medicine Payment Advisory Group. And I want to briefly kind of show kind of how we thought about this at that level. And then we'll kind of go into some payment reimbursement discussions. But what we do is we started sort of to the left of the screen, and we looked at the innovation, and we just asked a simple question, does this work? I mean, is this, from a clinical perspective, ready for prime time? And we started to aggregate an evidence database to inform those discussions. The advisors, there were about 15 of us. We had certainly physicians involved. We had payment experts. We had CPT coding experts. We had individuals from industry. And then we evolved, and we got to the question that as we aggregate our evidence base, we proceeded to the question that we knew physicians were going to ask is, will I get paid for this service? And we looked at coding, we looked at payment policy, we looked at pricing, we looked at some of the coverage policies, which we'll discuss shortly. We looked at liability, and then we evolved that into sort of moving to the right of the screen is now, can we address liability, and we can address what's going to be discussed in this call is, does it work in my practice? What's the evidence base there to support that? And there's a few of our accomplishments there, and many of the codes I'm going to discuss and some of the policies I'm going to discuss today are in many ways a direct product of the actions of this group. But to be clear, they are very much the product of local innovation, local experience, translating into national policy. And those that have heard me speak before know how strongly I feel that we at the AMA, by definition, are a national organization, but our responsibility is to be responsive to the states and be responsive to the local practices and the physicians to inform policy and implement policy that allows those physicians to do what they do best. So what we're going to do is I want to walk through, and I'm going to base my comments largely on what we sort of generically think of as the revenue cycle. I'm going to start with coding, we'll venture into payment, and we'll venture into coverage. And to build on Dr. Libby's point, what we're seeing from a coverage perspective, none of us could have predicted how wide open this space has become. And I'm going to walk through some of those coverage changes just so we have an understanding of how that relates to what we were experiencing previously. So let's start, and I want to talk about coding. And for those of us that aren't necessarily in the coding space, when you hear the word coding, you think, oh, great, here it comes. This is a bunch of 5-digit numerals and a bunch of long descriptors, and it's going to be hard to follow. And to be fair, in the coding space, in some ways, that's what it is. But I want us to take a step back, and I want us to think of coding more in the sense of nomenclature and more in the sense of how we can develop a standardized taxonomy. So frankly, we're, as physicians, talking in the same language with the same voice. But as we translate those codes and that nomenclature to things like payment policy, but equally important is research, epidemiology, disease tracking, health policy research. This is our language, and this is what we have the ability through the AMA to inform. We're the ones that go to the table and present these codes, present the data that supports their existence, and moves these forward. So we're going to walk through, in the spirit of us speaking in a common language, we're going to walk through what those codes are. I do want to define a term, because this is, as we talk about how we're going to classify these individual codes related to telehealth, this is a differentiation that we found helpful, and that's synchronous, which is essentially real-time two-way audio exchange, which is generally how telehealth has been covered. But there's also a significant interest in asynchronous, which is store and forward technologies, to some degree remote patient monitoring. And I'm going to kind of walk through, and this is a very dense slide. Now, by no means am I going to go through this, but I wanted to share it just because it's an example of how we're kind of thinking about this at the AMA level to propose a taxonomy or a coding structure. And this isn't quite in the public domain, but I checked with the AMA and our coding experts, and they were completely supportive of me sharing this. I do have a version of this slide that has the individual CPT codes included, but I wanted to share it for reference because it's going to guide the next few slides as I discuss kind of the general structure of this codes. And again, once we have that coding base and that coding nomenclature, we'll move on to other discussions on how those codes are applied to some of the questions and comments I've already heard during this session. So let's start to kind of the left of the screen, which is the patient-physician visit. And let's walk through what some of those existing codes are. So when we talk about patient physicians, or QHPs, which are qualified health professionals, that's a term we use within the coding space to describe non-physicians that are providing direct patient care. So within the synchronous space, this is kind of what we have. We certainly have evaluation and management codes. Those are the office-based codes and some of the new and established codes themselves. In general, we use a modifier 95 to increase telehealth. I'm going to talk about this within the context of COVID-19 shortly, but this is the standard nomenclature initially. It was mentioned we have telephone or audio only codes to describe those services. And then we have some other ones which are virtual check-in codes. As we venture to asynchronous, we have some of these. We have online digital evaluation for both physicians and non-physicians, and even the virtual check-in code that could be applied for these type of patient-physician interactions. We also have physician-to-physician codes for telehealth-related encounters. And these are essentially interprofessional consultations. These are the codes. These can be online. These could be via the internet. This could be through one's EHR. And those are a little bit of both. They're both kind of synchronous, and they can be a real-time interface, or they could be asynchronous, where you're having an interface where questions is posed and answers responded, and so on as part of a broader conversation. Dr. Libby and some others have already mentioned remote patient monitoring. Before I talk about those codes, I want to kind of take a step back as far as how some of the coding nomenclature is managed. So when we talk about, and this is payment policy in general, we have relative value units which determine payment. And there is a professional or work component, a work RVU, if you will, and there is a technical component, or what we refer to as a practice expense component to that total RVU. There's also a malpractice component, which has a different methodology. It's equally relevant, but the methodology is a bit different. I won't dig into that specifically, although I'm glad to answer questions if we have some regarding how those are determined. In some settings, particularly radiology, when these two are performed together, it's referred to as the global payment. So when we talk about these types of services, it's important to differentiate them, particularly within the context of remote patient monitoring, because we do have quite a few, quote, technical component only or practice expense only codes. So when we think about remote patient monitoring, there's kind of four sort of buckets, if you will, where these codes exist. There's setup and education, because you have to get the patient comfortable with the equipment. You have to introduce them to the equipment. This requires, in general, clinical staff, can involve physicians as well. Certainly the supplies, data collection, and then data analysis and interpretation, which generally goes into the physician QHP side. And here's some of those codes. We have general remote patient monitoring codes. These are generally technical component only, but you see the general, you see ambulatory blood glucose. There's some for cardiovascular telemetry. We have some supplies which are more general, and then we have the data collection. As we venture into the more professional component side, there's general interpretation, ambulatory blood glucose, which is interpreting the data, but also to some degree acting on the data, and then CV telemetry. To be fair, the rules regarding these codes are relatively granular and they're relatively specific and need to be considered within the context of when I'm seeing a patient for an evaluation and management service in my office via telehealth, and to be mindful of those rules. But we've really tried to be purposeful as we've created these codes to create them in a manner that is acceptable to payers who might be concerned about duplication of work or duplication of services, but also enable physicians and providers to use these codes in a meaningful manner for the types of financial analyses which Meg alluded to and which others will probably discuss later this morning. I'm not going to say a lot about payment, not that I don't think it's hugely important. And in full disclosure, I'm actually a member of a group called the RBS Update Committee, or the RUC. There's about 29 to 30 of us. We meet 3 times a year and we determine relativity of services. But I do want to point out that if you Google physician fee schedule search, you can look up any of the codes that I've presented so far, and you can break it down by your geographic domain and see what those payment amounts would be, at least from a Medicare perspective. Those Medicare physician fee schedules largely will translate into private payers to some degree, but that is a completely different set of databases that's contract determined, that is determined based on individuals within different institutions. And it's really hard to bring all of that data together. But if you're just looking for some just very general guidance on what the payment amounts are, this is a really appropriate and important resource to pursue. Okay, so now let's venture into coverage. And to build on the point that I thought Dr. Libby made in a really important manner is coverage has completely changed as a result of the disease. You know, what we saw from a coverage perspective pre-COVID, and to build on Dr. Libby's point, you know, what we literally fought for years to accomplish, I mean, almost overnight has been completely turned around. And a lot of this was some of the initial executive orders that were signed by the president, but a lot of this is coming in some out of the CARES Act, but really the majority of this came out of the interim final rule, which is related to COVID, which was released earlier this week on Monday. And I'm going to walk through those changes, understanding that what I'm describing is in place from at least a COVID perspective during the emergency declaration, which hopefully will end sooner than later, but it's during the period that actually applies. So let's just kind of touch a little bit on the pre-COVID. These were some of the challenges we were facing pre-COVID, or originating site restrictions on where patients could be located. Did they have to go to an office setting to have the telemedicine, to have the telemetry interface translated to a physician in his or her office? There were geographic limitations to where patients could be located, rural versus urban, restrictions on store and forward. You could use it in Alaska and Hawaii, but it was difficult to use elsewhere, what providers could provide it, even the services covered, as far as what we were able to provide from that perspective. We've tried several times. The Connect Act of 2017 and 2019 are two examples where we've tried to get legislative relief to allow greater remote patient monitoring access, expanding some of the originating sites to some of that I've listed here, clarification on how remuneration for these services. And we've made some gains. They've been incremental gains, mostly through regulations as far as what's being covered. And to repeat the point, the institutions, the physicians, the Dr. Libby's of the world, they weren't waiting for this legislation and these regulations to catch up. They were pushing forward innovation because they saw it was necessary and they saw that it was the right thing to do. So we were playing a little bit of catch up, but it's a responsibility that those of us in this space are taking extremely seriously. Okay. Now let's talk post-COVID, and let's talk about what's happened based recently. In general, this is what we're seeing as far as how the new regulations are applied. As I mentioned, it is during the public health emergency declaration, which the president declared in early March. Essentially, all beneficiaries from a Medicare perspective are eligible, and that's new and established patients. Recall that prior there were several restrictions regarding telehealth for being required only for established patients that had previously had a face-to-face office encounter. That is no longer the case. It's essentially wherever they are located or the provider are located. And you can imagine physicians at home talking to patients at home for all the reasons we've already described. And then there's been guidance largely from the OIG that we can waive Medicare copayments, deductibles, coinsurance, things of that sort. Before I talk about the evaluation and management services, because I think this is in many ways the largest piece, and it gets to some of the questions asked about earlier already on this call. So when we talk about payment policy, I've already mentioned we talk professional component and technical component, but we also talk about facility versus non-facility. So the facility is if we're providing services in a hospital. Imagine we have a clinic. In my case, I see some transplant patients at my clinic. We have a clinic that's basically part of the hospital. We build a facility setting. Now imagine conversely that we have a physician office separate from the hospital. Maybe it's in a medical office building or a single standing facility or building office. That's the non-facility setting. And for payment reasons, those amounts are different. And we could talk all day about the implications of that from a site neutral, budget neutrality perspective, but just understand that when we bill for our services, there may be differences in payment. In general, the office-based payments are higher, although that's not always the case, and that requires a specific evaluation. So keep that point in mind as we talk about the evaluation management, because I'm going to make a point about how these should or could be billed during this setting that we're in. So when we talk about E&M services, and this was one of the first things this is part of the executive order very early in the crisis in early March, it was expressed that CMS would pay for telehealth services at the same rate as face-to-face office visits. And this was an important change. The premise being exactly as Dr. Libby said, to work to keep patients from unnecessary exposure and traveling unnecessarily. This was for all diagnoses, not just COVID related. And when this is provided, this is an important point, when these services are provided in the office setting, it is important, we're recommending, or we believe you should bill based on the place of service that is the office, which is POS code 11, applying the modifier 95, because that billing process will enable the higher non-facility payment rate. And that's where you're providing the service, so that's justified. If you bill that service with place of service 2, which is telehealth, which would be otherwise objectively a very reasonable way to do it, the payment's based on the facility rate, which is generally lower in most Medicare jurisdictions. The code selection, this is another very important point. When we're billing the E&M codes, and it builds on some of the questions we've already heard about physical exams, and to be clear, as Dr. Libby said, there's means to provide physical exams by telemedicine and telehealth. There are applications. I talk to the vendors all the time about different applications and different technologies to allow, and it's not just remote patient monitoring, but to allow immediate monitoring of different physiologic parameters. So this technology is there. But if we look at the E&M codes comparing as they currently exist versus E&M codes which have been revised in their structure, the coding numbers are the same, but the coding structure, the descriptors, and the billing documentation requirements have been updated. So going forward in 2021, when we bill an E&M code, no longer is it present history, present illness, physical exam, medical decision-making. Now the code selection going forward will be based on time or the complexity or level of medical decision-making. Okay, those are 2021 requirements, but the interim final rule stated, for the very reasons we've described, that the code selection currently during the crisis will be based not on the physical exam, but time and medical decision-making. So when we interface with the patient by telehealth during the crisis, even though technically you're not doing what we would think of as an face-to-face physical exam, that doesn't and it shouldn't limit the codes that we provide. A couple of other points. Physicians may provide telehealth services in their home without having to go through the Medicare updates to their enrollment file. The licensure piece is pretty significant. You know, we've been in several discussions regarding licensure, and you have to understand, licensure from a constitutional perspective is the right of the states based on their constitutional responsibility to protect their citizens. Okay, that's great on paper, that's fine, but on a practical level, from a telehealth perspective, it can be burdensome, it can be restricting. So during the crisis, physicians licensed in one state may provide services in another state because that's the right thing to do in a crisis. Now, state laws do apply, so it's not a complete free pass, but it is relevant for our discussions. And then lastly, as far as medical screening exams, which are a requirement under EMTALA, before those were required face-to-face, those can now be provided by telehealth. There's some substance abuse-related aspects just to help and minimize those that are facing this disorder to receive the evaluations and allowing physicians to treat those patients appropriately. Some technology considerations, we've kind of touched on a couple of those, Dr. Libby did, but just to kind of bring those together, essentially any audio two-way interface will do. And the ones that we're seeing commonly described are FaceTime, Skype, and Zoom. Importantly, this does not allow us to use Facebook Live, Twitch, TikTok, any interface that would otherwise allow a public-facing component to it, which kind of makes sense. These are still very personal interactions we're having between the physician and the patient, and they don't want to be live. I will make a quick comment, if I may, and this is some experience we're having locally, but what I'm hearing nationally is there are some centers where, I think Dr. Libby is a good example, some centers where they're set up with their EHR, they're set up for the audiovisual two-way communication, but there are many centers where that's just not the case. And it's not just the patient side, it's the physician side as well. And it's not across one age group versus another, it's across all age groups. So what we're seeing is in the setting of a crisis where we're learning a new technology, where we're being called to the forefront to provide these services, we're falling back in many ways on the telephone. And I think that's completely appropriate. Patients in a time of crisis that aren't familiar with these types of interfaces would much rather just pick up the phone and talk to their physician. And we'll talk in a moment about what the payment considerations are regarding the telephone, but that's something that I've already heard on this call and that I will tell you that we're hearing most unquestionably nationally. As far as some other rules, so the Office of Civil Rights, the OCR, has come out and said that they're going to allow enforcement discretion on security and HIPAA payments and business associate agreements. I will say there are a few applications for this types of telehealth interfaces that we think are going to comply with the BAA requirements, and some of these are UpDocs and Zoom for Healthcare, G Suite, Google G Suite, Hangouts, etc. I haven't seen this in paper as guidance from the ONC or the OIG or the OCR, but I understand from discussions that this is forthcoming. If others have seen that, please share, because I think it's important. And then lastly, as far as the potential security risk, it probably is a responsible thing for physicians to at least let patients know in a manner that doesn't jeopardize their confidence in that interaction, but does allow us to at least communicate that this is a different paradigm for both of us, patient and physician included. This is a really big deal. The expanded list of services is completely different than what we saw before. I mean, now it's not just office-based. I mean, it's everything before you I'm listing here. And there's more. It's neonatal, it's physical therapy, it's radiation treatment management, it's social workers. I mean, it's really almost everything that we probably, if we had the collective desire to do and we wanted to achieve what I'm showing on this slide, would probably take us years of effort that we just saw completely change overnight, albeit temporarily, but it changed overnight. And I'm just going to take this opportunity to make this comment. We're going to find ourselves 6 months from now, a year from now, looking back on this period from a historical perspective. And I think now's the time for us to respond to the crisis, to do what physicians do to save lives. But we want to be sure that we learn from this experience and that we show that this technology is ready for prime time and that we maintain the quality. Because if CMS, I said this on the call yesterday with the White House, is if CMS is allowing laxity to the requirements and the expectations of physicians in the short term, it is incumbent on physicians to assume that responsibility, take it seriously, and prove that we're allowing it. And I'm not for a second implying that we're not. I'm just telling my physicians locally that even though you're sitting at home interfacing with the patient, step up and take that interaction seriously. Provide the documentation as necessary, and put yourself into that kind of work zone, if you will, during those interactions. And without question, physicians are stepping up, and it's really a pleasure to see. There's a few other aspects. There's coverage now for virtual check-ins. And recall, this was for established patients. Well, now it's new and established patients. The expanded providers that we're seeing for these e-visits with some of the codes I provided here are included before you. The telephonic codes. So one of the things we heard on the call yesterday that I want to highlight is, from a payment perspective, the E&M codes pay more than the telephonic codes. And we can walk through, if we have time, how that happened at the RUC. I was involved in some of those discussions, but just suffice it to say that we're hearing from physicians in the community that what they would like to be able to do is providing evaluation management service over the telephone for the reasons I described and bill it as an E&M, as opposed to the 3 codes or the 6 codes I'm showing before you now, which are telephonic specific codes, which are covered, but the payment amount is less. And I think CMS is hearing this. I can't promise they're going to make that update, but Seema Verma, the CMS administrator, yesterday on the call made the point several times that they are hearing this feedback. And to be frank, it's coming from physicians that are financially stressed based on the circumstances for a number of reasons, which are completely appropriate and completely understandable for them to express. Remote patient monitoring, a couple of updates there. It can now be applied to both new and established patients. It's acute and chronic conditions. And instead of being multiple diseases, some of the codes require 2, 3 diseases to be included as far as chronic management of patients. It can be only 1 disease. And for my coding folks on the call, I did go ahead and include the CPT codes before you. Some frequency limitation changes. I won't read through these, but understand some of the requirements for how many visits had to occur within certain timeframes have been loosened up. Then there's some others regarding ESRD patients, national determinations and local that require face-to-face, that is now waived on some services. The beneficiary consent, it's not required that we do that before the service. We can do it at the same time of the service. But again, it's not necessarily something that we have to hamper that interaction with. And there's some requirements around nursing homes. Quick point, if I may, regarding the consent. We're hearing about experiences, and the experience I heard from Ohio yesterday, where the numbers, round numbers, where before COVID, they had 47 providers and they had provided 500-600 e-health visits that we're discussing today. Since the COVID crisis has occurred, they now have 1,000 different providers, mostly physicians, and they've provided over 10,000 telehealth visits in 6 weeks. I mean, the numbers are staggering. But what that means is we're seeing physicians entering the telehealth space that haven't done so before, just by pure circumstance. And one of the things that we're telling CMS at the AMA level, and we're thanking CMS, is that they're loosening these security requirements and they're loosening the HIPAA requirements, because you don't want these physicians who are in good faith entering these types of interactions worrying that the OIG is looking over their shoulder, or that their medical license could be threatened, or they could have some liability consequences. And I think it's a really important point for those of us on this call to communicate in our discussions, which we're having at the federal level, but clearly and unquestionably at the state and the local level, and with private payers, by the way. Okay, so let's kind of venture now and talk a little bit about it. That was pretty much the majority of my talk. I'm going to kind of bring it together to a couple of points which are going to be relevant to our discussion today. What are we seeing at the state and what are we seeing with the non-government payers? A little bit about what we're seeing in the state of Texas, and anyone from the TMA, please, after my talk, feel free to add to this or correct any comments that I make. And in fact, anything that I've said before this, anyone in this group, if there's something I misstated or I need to research further, we're very much learning on the fly in a crisis mode. So I'm really trying to do my best to present what's accurate, but I do fully recognize and appreciate that some of this may need to be, revisited or discussed. That said, let's talk about what we're seeing in Texas. So we're seeing Texas, the governor of Texas, Greg Abbott, has come out and said that the state regulated plans are eligible for payment for medical visits conducted over the phone at the same rate as the in-person visits. Okay. Recognize for a moment that I just said that at the federal level, what I just described does not apply. In other words, the telephone visits are being paid on a different fee schedule. And why that's relevant is we're sort of managing a little bit of a dance here between what the federal government is allowing and what the states are allowing, where the states may be a little bit more liberal in what they're allowing us to offer. And we don't want to jeopardize what's happening at the state level with federal policy, but we want to kind of pursue this goal where there's at least some continuity across the payers and across policies. This does include Medicaid within the state of Texas. And in general, we're seeing the private payers following. But again, it's a very heterogeneous landscape, and I'm sure the experience in Florida and Massachusetts is similar. So let's talk about what we do in this scenario. Oops, I'm not getting paid. We had this great meeting on Saturday morning. We brought all this information together, and now this is my circumstance. Just a few examples. This is a little bit of what we have in Texas. We do have a hassle log factor. There's the website where our physicians can log in, they can document sort of what their experience was. This is generally at the private payer level. And we periodically meet with the different medical directors for, the big insurance carriers, the Aetna, the Cigna, the Blue Cross in our state. And it gives us a chance to objectively share what those experiences are and potentially try to find some relief for our physicians. We did ask the question in Massachusetts, and I'm hesitant to speak for the state because I think you're going to have a chance to speak for your experience, but this is just some of what was communicated. This Physician Resource Center, there's an email to communicate exactly the same types of experiences. And I really appreciated what we heard from Florida because I think Florida really captures what is at a higher level, really what we do at the State Medical Association level and what we largely do at the institutional level, which is this. Is we listen to and we work with local practices, we interface with the payers, we interface with the regulatory agencies, we engage our coders, we engage their coders. We have legal looking at the different policies that are in place, and we make informed discussions. I mean, this is the core of what we do and what we have the resources to provide, again, at the state level, at the federal level. And I'll just take one quick moment to repeat the point is what we do at the AMA level, at the national level, and this is certainly at the House of Delegates, and let's be fair, I mean, it's what we do in that room. But in many ways, it's those interactions we have with the state medical associations to learn what those experiences are, where others are experiencing that at the state level, and what we can do at the federal level to provide relief. And we have some extremely talented, many of whom are on this call today, but extremely talented staff at the AMA level, that dedicate their careers and dedicate themselves to working for physicians in this regard. I'm going to close with my last slide. I mentioned the Digital Medicine Payment Advisory Group at the beginning, and this is kind of where we are. And this was a pre-COVID slide. I don't have a great sense of where we're going to be immediately after this crisis resolves, but I've already talked about the taxonomy we were creating. We're looking at how we're going to define things like face-to-face within the coding set. We're looking at metrics to evaluate and gauge the efficiency of the type of digital medicine interfaces we're discussing. We're digging very aggressively into augmented intelligence and trying to find ways, in the same way that we're standardizing the taxonomy for digital health and telehealth, standardizing the taxonomy for augmented intelligence. What is supervised learning versus unsupervised learning? What is a locked system versus a continuously learning system? And we're engaging data scientists from across the country to inform that, again, under the premise that this is happening already. The vendors are driving this. If you look at the 80,000 patents that have been filed for augmented intelligence, a third of those are in healthcare over the last 6 years. I mean, this is a very rapidly evolving space. And it's the AMAs and it's our premise and our continued assertion that the physicians need to be involved in informing these discussions, and we are. And then we're looking from the advocacy side. I mean, some of what I'm describing here was stuff we were fighting for late last year, which has already been relieved, if you will, from the COVID. And then lastly, I think we do have a responsibility, and I think Dr. Libby touched on it, to really look at what the evidence is for what we are doing, the data, the effectiveness from a clinical side, what the provider's experience is, justification for coverage expansion, and in the numbers that we're seeing in the COVID crisis, they are literally a laboratory to inform these discussions. We're going to have to be responsible and purposeful once we survive this crisis collectively to take the steps to inform how the telehealth space is going to evolve going forward. With that said, I want to thank Shannon and the TMA team for including me, the AMA staff, and everyone that took the time to listen to my comments. Thank you again, and I'll be on for the duration if there are other questions. Shannon, I think I can stop the share on the screen and send it back to you. Thank you.
Perfect. Thank you so much, Dr. Silva. Excellent information. Meg, I noticed quite a few questions coming in the chat function if you'd like to start with those. And while we do that, I just want to state that while we do this Q&A, if you need a quick bio break, by all means, we understand if you need to step away for a minute, but otherwise we'll continue with questions and discussion. Go ahead, Meg.
Great. Yeah, and thanks everyone for chiming in and responding as you see fit to the chat here. The first question that I think has gone unanswered, though, is from Kulang in Florida. And we've heard insurance will decrease payment if we put in a modifier. How do we handle them? Dr. Silva, do you want to take that first?
Yeah, no, it's an important point. It kind of gets into that facility, non-facility discussion where we're recommending the place of service for the office when that applies with the 95 modifier to indicate the service. There is, as you know, a telehealth modifier, which is O2, which could be applied to the code as the place of service. But I think we want to look at those fee schedules because I speak with confidence about the evaluation and management piece, but there may be differences in some of the other codes we described, some of the wellness visits and some of the critical care and other services you might see in our community where we're going to want to look at those more specifically to ensure those amounts. And I predict this is probably guidance that we're working on at the AMA level as far as some coding scenarios. I didn't talk about diagnosis coding. I didn't talk specifically about some of the other policies and how we indicate, lab services and how we indicate those types of consultative services. But it all kind of fits into the same question, which is an important one. Thank you.
Great. The next question was from Amy and said, any update on CMS reimbursement for codes 99441-3? To my knowledge, those fees have not been published yet.
Yeah, it's an important question. So those actually codes did go through the RUC process and they do have valuations. So for others, those are basically the telephonic codes. And the way they're structured is they're based on time. So I think the first code is 5 to 10 minutes of telephone time, and it goes incrementally up from there. So the AMA and the RUC, we have shared with CMS our recommendations, and that's based on surveys of physicians. It's what we do at the RUC to value services. CMS has those, as you've correctly stated, those are not covered services in the pre-COVID world. So CMS is going to have to provide those updates, and we anticipate that if it already hasn't happened, anticipate that shortly. And it is an important question. Thank you.
Yeah. Then there was a number of questions from MMS, and Chris, I'll do my best to summarize here, but a lot of it related to physicals and doing adult and well child visits, and understand that a lot of that can be done by telehealth. But the key question around can enough of a visit be done so that we meet the criteria set out by codes 99391-6, and can we do enough of a physical to check enough boxes so that we meet the requirements? Is really the summarized version.
Yeah. This is, I think Dr. Libby's answer earlier, I thought maybe I'll defer to him shortly, but just from a pure coding perspective, and I'm going to look at my database while Dr. Libby's speaking, but those are codes that, to my knowledge, CMS hasn't specifically come out and said that the physical exam is waived in the same way that the evaluation and management codes. So when we look at the sort of larger family of E&M codes, the only family that's specifically gone through the revisions I've described for 2021 is the office-based codes, which are new and established codes, which I showed. It's logical to think that the other codes, for example, these codes themselves, or imagine ICU visits and codes of that sort, because the coding structure, we might want that to be parallel between the two, that there may be a revision, but that hasn't happened yet. So I think it's an important question, because if that physical exam face-to-face, hands-on is required, it is troublesome to be able to build those codes. But again, this is the kind of question that we can take back to CMS, back to the policymakers, and encourage that they allow some physician relief if we determine that's appropriate. Dr. Libby?
Yeah, it's sort of like the Wild West right now. I think that nobody's going to be scrutinizing how you care for your patients as long as the outcomes are appropriate for the situation. I think for those of us who are established in practice and have those patient-physician relationships, they aren't going to be scrutinized in any way that's going to put your coding in jeopardy. What we experience will be what we observe over the next few weeks and months to see how the payers reimburse based upon the coding that you use to devise and develop the parameters around which you will qualify what your visit was worth. I mean, these are things that there is no established baseline from which to derive an answer easily anyway. So I think that we will define, this is something that we have to lead. And I really appreciate Zeke's presentation. I think it was really comprehensive and very, very, visionary in terms of how this is going to unfold. I think we have to establish the database. We have to be able to interpret how it is applied, and we have to be part of that guidance that does give CMS and the payers the insights they know they need to be able to make this work.
Yeah, Dr. Libby, thank you. This is Zeke Silva. If I build on those comments. So while Dr. Libby was talking, I actually looked in the database at those codes, the 99391-3. And to the point of the question, the physical exam is required, and it's weight, length, head circumference. It's things that pediatricians appropriately do with every one of their patients. I don't have an answer to if that's going to be waived from a telehealth perspective. To Dr. Libby's point, I think if we do our best and we document as best as we can, the fact that we're keeping patients protected from unnecessary exposures, I think justifies the action. But after the call, I mean, I would welcome emailing Meg Stacy or any of the AMA staff with that question and that potential need. And I'm pretty confident that would probably be something that would be pretty easily kicked up to the federal level.
Yeah, I think that's a great point, Dr. Silva. Anything that is currently, a little murky or unanswered, we can definitely take back and make sure we're raising that to the right folks internally. The next question was from Sujath around, is palliative service covered under telehealth?
Yeah, this is Zeke Silva. I'd have to look more specifically in the final rule. I don't have off the top of my head. Maybe while other questions are coming up, I can do a little bit of research and see if I can answer that question.
Sure. And Dr. Silva, on one of your slides, there was a question regarding you had domicile specified versus home. Is there any differentiation there, or is that one and the same?
I'm sorry, you broke up real quickly there. Ask me that question again, Meg.
On one of the slides, domicile was listed versus home visits, and we were curious if there's any differentiation there.
Well, there is from a coding perspective. There are different CPT codes for each one of those settings. I don't use those in my practice, so I defer to others as far as the nature of the requirements. And but yeah, there are different CPT codes, which is why I indicated those specifically. And that's enough. We can dig into those and see if there's requirements that we may need to loosen.
Great. All right, let's see. See what we got here. Okay, Dr. Silva, when speaking about TMA hassle-free log, you briefly mentioned that Florida made some positive advances. Can you elaborate, please?
Well, I would defer to Florida on that, but I guess my point with the Florida was that I think what they're describing is what we're all essentially doing ourselves, which is building relationships, ensuring that we have a discussion forum with the private payers so that when we see policies affecting physicians at the individual practice level or the institutional level, that we can kick those up pretty quickly. But, I defer to Florida regarding what their direct experience is. Maybe we'll have time later in the call to share some of those ideas.
Mm-hmm. Matt, anything your team wants to jump in for that one?
I think you hit pretty well. I'm going to let Jared take over because that's kind of Jared's forte.
Yeah, absolutely. What Dr. Silva says is correct. I mean, we just do our best to work with our members and, keep everybody up to date. We work directly and contact the payers in our state regularly. And we do have a certified coder on our staff, as well as 2 staff attorneys who I work with on any legal issues surrounding telemedicine. But the bottom line is, in Florida, one, as far as the way our laws are working, we don't have a uniform payer requirement under Florida. I've asked our insurance commissioner in this time of crisis to effectively require all payers to reimburse for telehealth services at parity within person visits. But currently, there is a variation across the board in terms of what private payers in the state of Florida will pay for. And addressing that has been our biggest obstacle, but we are doing our best to educate our members, and we have a robust payment advocacy service for our members. So from that perspective, we're continuing to do sort of the same sort of work that you mentioned, sir. And in any case, just trying to get the private payers on board, preferably through our insurance commissioner, is really I think our number one objective at the state advocacy level at the moment, telehealth wise. Thank you.
Great. Shannon, how are we on time? Can I keep going with a few more, or?
I would say we probably need to move on to the next section, but we hold your questions because we will have some time for open discussion at the end. But for sake of time, maybe we should go on to the next section. And thanks everybody for the great questions and great discussion, really important.